So in my time in the work, I will be discussing some findings from the work we did, of course, with Cheyenne and the team, around understanding the multiple social norms behind informal payments in the Nigerian primary healthcare sector. For the purpose of this work, we did work in three Nigerian states, conducted about 156 interviews, and interviewed close to 366 participants doing FGDs, IDIs, and KIIs. And this stemmed out of the fact that informal payments in the Nigerian healthcare sector, primarily the primary healthcare sector is widespread, and then health workers in these PHCs often solicit or accept extra payment for services. And some of these services are either for drugs, medications, or for vaccines. And like I mentioned, our study location was primarily because we're also looking at some intersectional factors around faith and religion. So we selected those locations based on data available for those states. What were some of the things we were finding? As regarding gender, we began to see how gender and social norms shapes who pays, who benefits, and who resists. Who pays these extra charges or payments, who benefits from this payment, and who resists, right? And then in talking about who pays, it was very clear that some service users, especially women, may feel less able to challenge the health workers asking for these payments. And then it's difficult for them to resist, paying these charges because they are women and they have less agency to stand their ground and say, oh no, I wouldn't pay this, compared to men who could just come and throw tantrums in the health facility, and then at the end of the day, they might, go off not paying paying these extra charges. So the report really noted that female service users were aware that these payments were wrong, but they still felt the need to pay, to get these access to services. Now, who benefits? Health workers generally benefit from the normalization of this social expectation, and the social expectation that you have to pay extra charges when you go to receive services in the health facility. And then most times they encourage this payment. And just like Cheyenne had mentioned in the introduction, for health workers who do not adhere to this norm of receiving this payment, they often face some level of sanction, some of which includes sidelining them in the health facility, or even introducing them, or even transferring them far away from the health facility. And it's also important to note that health workers, both male and female, typically ask for this informal payment, or which is like a descriptive norm, or they are also experience some level of social pressure to collect this payment, and they believe that either colleagues or supervisors expect them to solicit or receive this kind of payment. However, it is noteworthy that the community places an indirect pressure on these health workers to receive these informal payments. Now, health workers are members of the community, and so they are workers in the communities. And there are these demands on trying to meet the community needs in maybe contributing for a family function or meeting the need of a family member who really does not have a job and needs their money. So that places an indirect pressure on the health workers to begin to, ask for this informal payment, especially where their salaries are really not enough to meet the needs for which the community members or their family members are putting pressure on them for. However, these pressures override the health workers' attitude. So, for example, although some people view informal payment as inappropriate, the female health workers, even more than male workers, did believe that most believe that these charges are very inappropriate, and so they really do not subscribe to it. However, it's also worthy to note that because of the extra pressure on men to meet the family demands and try to, meet the needs of their family, then that places an extra pressure on them to request or receive these unauthorized charges. Um, So there were a lot of intersections between culture, and especially within the facility and the community, and then the gender norms. So the gender norms inside the facility, the report pointed out to the unspoken facility norms. For example, being a good health worker means that you're delivering services without extra reward, but at the same time, the prevailing norm is to collect payment. And so female health workers may feel the tension more acutely, and the expectation of care and services which is expected of a woman. And then there's also that point of we need to gather extra payment to meet the needs of our family. So you see that as women, they face the extra dilemma of trying to be good, show care, and then trying to meet the demands of their family. Also, especially because um, there's also the new, I wouldn't call it new, but the demand on women to begin to meet the needs of their family as well, and not just place all of those responsibility on the men. So you see female health workers trying so hard to also meet the needs of their families by receiving or requesting for these informal charges. So just to summarize, and then I'm sure we'll have a lot of time to talk about this in the breakout. One, informal payment in the health sector is normalized through social norms that is not just driven by material shortages. And secondly, health workers operate in a normative context where asking for or receiving this informal payment is expected, and it's often reinforced by peer culture, institutional silence, and gender role expectations, like I mentioned earlier. Thirdly, gender norms matter, and this is because female health workers may view such payments as inappropriate, and they face a different kind of pressure to receive these charges, and they may be less likely to challenge the norm. And then finally, we had also mentioned that some form of effective anti-corruption efforts must go beyond just engaging the health workers, but must also address the social norms that drive this receiving or asking for these informal charges in the health commodities.